fellows have all taken that little image there. There's some very basic stuff in here and some very advanced stuff. So I think I have something for everybody, hopefully. And we'll go ahead and get started. So pathophysiology of chronic venous insufficiency. The significance of the veins. Most of the blood in your body is in your legs, and 60 to 70% of the blood is in your venous system, and 40% of that is in your legs. So just a review on venous anatomy. Your veins, you have the tunica intima, which is the endothelium, the tunica media, which is the smooth muscle, and the tunica externa, which is the collagen, and that's for your stability. On the anatomy, the deep system handles about 90% of the venous blood volume, whereas the superficial system handles about 10% of the volume. And the superficial system is very complex, but we break it down into the small saphenous vein, and the great saphenous vein, and tributaries. Now that is oversimplification. We also have perforating veins connecting the deep and the superficial vein system. And then we have the old nomenclature here with the Cockett's, Boyd's, Dodd's, and Hunterian perforators. I like to tell my patients to think of this as a roadmap this is, of course, Italy, with the femoral vein being the superhighway and the superficial system being the accessory drives or service drives, and the perforators being interchanges between the two systems. Now, there's a lot of different ways to name veins over the years. The nomenclature has changed, and I love it when my techs come and tell me that they have a vein of Jumanji, because they know I love the vein of Giacomini, but they sometimes misname it the vein of Jumanji. It's important to understand what the true names of the veins are in both the superficial and the deep system, and there is a approved nomenclature that was created by a combination of the AVF and the SVS. And I'm not going to go through all of these that you can see on this chart. Let me get this box out of the way. But basically, take a look through here. That vein of Jumanji or Giacomini, for example, is truly called the posterior thigh circumflex. It's a posterior thigh extension of the small saphenous vein. But it is important to really know what the true names of the superficial, the deep, and the perforators are. So this is a great chart to have as a reference. And this is a great chart for the deep or pelvic system. So you can just download that from my presentation afterwards. So we'll break it down to the valves. They're one-way valves, two cusps made up of a cytoskeleton. They close at a rate of 30 centimeters per second. The exception to veins having valves would be the IVC, the common iliacs, the portal vein, and the cranial sinus. Those veins do not have valves. And the venous pump or the calf muscle pump, they're large groups of muscles which compress the veins, and they're by opening the valves cephalad and closing the valves caudad. So we're going to look at that a little more closely here. There are 4 phases of the valve cycle. Phase number 1, or opening of the valve, is where the pressure caudad is higher than the pressure cephalad, so your feet to your head. And at that point, and this is when you're taking a step, the valves will start to open, and the blood is going straight through the center of the valves. On the second stage of valve opening is where you begin to see what is called vortical flow, where the flow goes in a circular motion behind the valve cusp. At equilibrium, the valves actually vibrate, and I'll show you an image of that, a live image of that in a moment. And there is vortical flow continuous around the valve cusps. Now, as the phase of relaxation begins, all of a sudden the pressure cephalad becomes greater than the pressure caudad, and the vortical flow becomes more significant, and then that is what forces these valve leaflets closed. So those are the 4 phases of the valve cycle. Here's an image, and this is courtesy of Dr. Pappas. This is an ultrasound image of opening and closing, and this is a venoscopy. Looks like a little fish mouth, but that is equilibrium, where the valves are vibrating. and the flow is equal on both sides. And you can see that on ultrasound too. And it's important to know these phases because the pathophysiology of venous reflux is what causes the difference in these phases of flow. And wherever you have low shear stress, where there is a low stress on the wall, is what starts the inflammatory cascade and platelet adhesion. And this is where you get thrombosis and inflammation and thrombophlebitis. And this is just a trick question for the fellows on the call. Who first described this complex system of phases of flow? And it was first described in the aortic valve sinuses of Valsalva. And the answer is Leonardo da Vinci. So this was something highly complex that he understood way back then. This is one of my favorites to talk about, is the flow in perforators. So normal flow dynamics in a perforator. On my picture here, this is the superficial system. Hopefully you can see my pointer. This is the deep system. And this little circle here represents the calf muscle pump or the muscle pump. And this branch is a perforator. So normally in the resting phase, blood is filling the deep veins and the pressure starts to rise. As you contract your muscle, the deep system compresses the fascial gates in the perforator, closing those valves, and then there is no flow between the superficial and deep system. However, on muscle relaxation, those valves open and it draws the blood from the superficial system into the deep. So the primary function of the perforator is to divert blood from the superficial system into the deep system. That way you're not waiting until you get to the saphenofemoral junction or the saphenopopliteal junction for the blood to get from superficial to deep. You have all of these perforators where the blood can flow, and those are those interchanges between the two highways. Now, it's important to know that there is bidirectional flow in a perforator, and some amount of bidirectional flow is normal. So as the muscle starts to contract, you will see flow from the deep to the superficial initially before the valves in the perforator close. So how do you know if you have a pathologic perforator or a refluxing perforator? By definition, a refluxing perforator, number one, has to be greater in size than 3.5 millimeters, and the reversal of flow has to be greater than 500 milliseconds or half a second. Also, it should be, in order to be considered pathologic, should be underneath a healed or active ulcer. These are the criteria that were put forth by the SVS and the AVF. There are two types of perforators, and I've talked to my nurses and my doctors about how to understand when to treat a perforator. So this concept is very important. The first type of perforator is what's called an antegrade or overflow perforator. This is where the primary problem is your superficial venous system. So you have primary superficial venous insufficiency, retrograde flow in that vein. The superficial system dilates out, and because of the high pressure now, the pressure being higher in the superficial system to the deep, you will see the blood flow from the superficial to the deep, dilating this perforator out over time due to the high flow in that area. Once the perforator dilates out, basically greater than 3.5 millimeters, the valve cusps don't approximate, and you will see pathologic reflux between the superficial and deep. So you will see flow from the deep then to the superficial. The second type of perforator incompetence is called retrograde. This type of incompetence is where the deep system is the primary problem. It usually comes from a proximal venous outflow obstruction. So when the deep system now dilates, you will get deep system insufficiency, which then causes overflow and pressure, high deep pressure from the deep to the superficial. And in this case, in the first case for antegrade, if you ablate the superficial system, you will correct that pressure, and then you will see the perforator will tend to resolve and the deep system reflux will resolve after you ablate the superficial system. However, in the retrograde or blowout, when the problem is primarily deep, you will see when you ablate the superficial system, you will not see a resolution of the perforator or the deep system reflux. So the mechanics of superficial or venous insufficiency involve venous stasis, structure, inflammation, pressure, DVT. We'll go through some of those. Basically, you have a valve problem is the bottom line. You can get inflammation, fibrosis, splitting, tearing. This can come from either your primary or inherited, where you just have fibrotic valves and you develop stagnation and microthrombi, or secondary from primary venous thrombosis that then causes secondary valve dysfunction. This is a venoscopy of a thrombosed valve. So you can see it kind of looks like hamburger meat. So you can imagine there's no opening and closing. It's just constantly torn and broken. So you're going to see complete reflux through that valve. For the fellows, I know all of the doctors on this talk or on this call have their own way of explaining this to their patients. And the fellows, you'll probably get your own little way to explain it, but I'll give you mine in case it rings true to you. But I explain to my patients that their circulation is like their water lines in their home. The arteries are the incoming water pipes and the veins are like the outgoing sewer pipes. So arteries are high pressure, veins are low pressure. I compare their calf muscle pump to a sump pump in their house. And I explain to them that every time they take a step, it's like that sump pump in their basement, which their legs are their basement, pushing the water or the blood up through their circulation or through their pipes to get to their main water tank on the main floor, which is their heart. I also explain to them when I have to talk about a perforator that it's also like that sump pump. You can see here, there's a perforated liner in your sump pump in the basement where the water can come through those perforators, and then the sump pump will suck it up and take it up into your main system. There's check valves in your sump pump, and I compare those check valves to the one-way valves in the veins. Most of the patients understand what a check valve is, and that makes sense to them. I also have these two little videos downloaded onto my desktops in the consultation room. If you want them, you can have this talk and just download them, but it shows the contraction and relaxation of the muscle as well as reflux, and then what reflux does and dilates out the axial system and the venous system. And this can also help make a little more sense to the patient. CEAP score, I know you've already had a lot of exposure on this, but there's CEAP class 1, spider veins, 2, varicose veins, 3, edema, 4, and this is not the updated CEAP score. I apologize for that. I will change this for my next year's talk, but CEAP 4 are the skin changes, 5, healed ulcer, and 6 is a venous ulcer. CEAP score, you always default to the highest level. So this guy has edema, which is a 3. He's got varicose veins, which is a 2, and he's got hyperpigmentation, which is a 4. So his CEAP score will be, the clinical component will be a 4. To my patients, again, when they get to that stage where they're a CEAP 4, and I'm trying to explain to them why they have those skin changes, I tell them about a sump pump failure and all the dirty water that collects in the basement. Again, the basement being their legs. So when their pipes aren't functioning properly and that dirty water will collect, you will see the skin staining. Of course, you know it's called hemosiderin staining or a deposition of iron pigmentation, which in the more advanced part of this talk later on, we're going to go into great detail about what that iron actually does and how it inhibits ulcer healing. When they do get an ulcer, it's just like a little blowout of a pipe. And I tell them the pipe under the highest pressure is the one down by your ankle bone. So that's the most likely place for you to get a blowout. And they tend to understand that. Why do they get a blowout? Normal pressure at your ankle should be 10 millimeters of mercury when you're in bed. The minute you drop your legs out of bed, it'll jump up to 9 millimeters of mercury, and it takes only 7 steps for a normal vein system for the pressure down at your ankle to drop to 25 to 35. That's why movement is so important. And people that are sitting at desk jobs all day or standing up all day and not moving around, say at a factory line in a auto industry, the pressure at their ankle might stay at 90 most of the day, even in a normal vein system if they're not moving. In a vein system that has venous insufficiency, you can take 7 steps, you can take as many steps as you want, but because of the insufficiency, the pressure at the ankle rarely drops below 80. So compare that to somebody with a normal vein system. You can see why somebody would develop an ulcer. It's also why compression garments are important. They're not going to prevent or reverse the disease, but it can certainly minimize the damage done to the skin and prevention of ulcers. Why are ulcers important? $15 billion a year are spent on ulcers. This does not include the venous portion of the treatment. This is the talk that I use when I go into factories and explain to the health management companies in these factories why treatment of venous disease is so important, why recognition and prevention are important. And some of the factories that we work with are Jeep, GM, and BP. And over the years, we've really managed to get a lot of these people to start wearing compression stockings. So it's pretty successful. Going more in depth into venous ulcers, the most common location for a venous ulcer is in the gator region, down by the medial ankle bone. Why is it called the gator region? It's the lower medial 1/3 of the leg. It's called the gator region because originally gaiters were protective leg garments that were worn by menders when they're used sewing or spinning machines to protect the lower medial portion of their leg from the spinning machine. So that's a gaiter. Today, as an equestrian, I call them half chaps, but that's exactly what these are for, padding down in the lower medial leg to prevent injury to that portion of your leg when you're riding a horse. As far as ulcers, we all know venous ulcers, we see them every day, but I'm pretty sure you might actually see more than just venous ulcers. You may see what's called mixed ulcers. They can be arterial, they can also be primary skin conditions, dermatologic conditions, and even medication-induced ulcers. I searched really hard, and I apologize. I have a ulcer patient that is classic lower medial leg, medial malleolus, and it was from hydroxyurea. It's a medication that classically can cause ulcers in the legs. And she just stopped taking the I did her scan, and there was no insufficiency or minor insufficiency. And she stopped taking the hydroxyurea, and the ulcer just healed right up. So it's also very important, and I know that Dr. Fernandez gives a fabulous dermatology or skin lecture, and that's where I learned most of mine. So hopefully he does that at some point, and you can begin to recognize these other ulcers. Another reason it's important to recognize mixed ulcers is because when you have a mixed ulcer, it doesn't mean you don't treat the venous disease. Yes, you treat the venous disease, but you also have to give reasonable expectations. This is one of my lupus patients, and she had a medial malleolar ulcer. So yeah, we did treat her ulcer, but I seriously doubt I'm going to improve the look of her skin and any of the damage that can occur from just her underlying lupus. The progressive stages of ulceration in a non-healing ulcer and in the acute phase, it's very boggy, irregular borders, fibrinous exudate in the middle, and as opposed to an arterial ulcer, which looks more like somebody used a hole punch to punch out the skin. And as the ulcer starts to heal, the fibrinous exudate clears up. You have a nice granulomatous base, and the edges start to slope in as they heal inwardly. Now, you will see there's little islands of tissue that we've started noticing that venous ulcers not only heal from the outside in, but they heal from the inside out. And this is something a little newer that we'll talk about a little more as to why that might be. So to look at that, this is where we get into the complex portion of the talk to the pathophysiology of the venous ulcer. I just gave this talk at AVLS, so if any of you saw that there, I apologize, but it's the same. And I like to make this a little more simple by comparing all of the components of the microcirculation to the Avengers, or what I call the Avengers. I know they're not all Avengers, but we have M, and that is the M1 and M2 macrophages. We have our transformers, which are the transforming growth factor beta family. We have Iron Man, which is iron, obviously, and we have our glycocalyx with her invisible force field. So we'll talk about each one of those. Most of you are very familiar in medical school. We talked about T cell differentiation. T cells differentiate into the T1 helper and the T2 suppressor. Well, monocytes differentiate too into M1 macrophages and M2 macrophages. M1 are the pro-inflammatory macrophages, and they are what are upregulated by the inflammatory cytokines. M2 are the tissue remodeling macrophages. And so those are the wound healing cytokines, as well as transforming growth factor beta. Here's a normal wound healing process. So you'll see the skin here, subcutaneous tissue. This little purple represents your injury or the wound. These are undifferentiated fibroblasts. And this is your venule, postcapillary venule with your leukocytes or monocytes. So when you have the original injury, these monocytes through diapedesis start headed out towards that injury. They walk towards the injury. They've got little granules inside that have not been released yet. They head straight to the injury and boom, they transform into the M1 phenotype. Those are from the cytokine signals in the endothelium that have signaled those macrophages to transform into M1s. M1s are the destructors. So you've got an injury, you've got to get rid of all the dead tissue. So these are the destructors. They upregulate the inflammatory cytokines, tumor necrosis factor alpha, IL-1, IL-6, and IL-23. And that causes these M1 phenotypes to upregulate. So you'll see more and more of those, and the dead tissue is destroyed. Now, the tumor necrosis factor alpha will also stimulate the M1s to now transform into M2s, the tissue remodeling macrophages. The M2 phenotype releases those little granules, and those granules are transforming growth factor beta. So we'll go into what is transforming growth factor beta. That's our transformer. It's the transformer. They control cell growth, proliferation, and apoptosis. So this is what causes all of your new cells to generate. So the transforming growth factor beta will also cause a differentiation of those undifferentiated fibroblasts into contractile myofibroblasts, which now start to pull the wound edges together. And the M1 or the M2 phenotype is upregulated by IL-4 and IL-3. And also the granules in those fibroblasts cause RAS activation. RAS is a small GTP binding protein responsible in cell signal transduction and regulation. And it causes MMP synthesis. Now, what is MMP? This is very important. Matrix metalloproteinase. So MMP causes a post-translational modification in your collagens. Now, remember the adventitia of the vein is the collagenous portion. So collagen type 1, 2, and 3. Collagen type 1 refers rigidity, so stiffness. Collagen type 3, elasticity. So the different MMPs will either upregulate or downregulate whether you're getting a rigid vein or a more elasticity in your vein, and also in the wound edges. So there you have it. Normal process, you get the destruction of the dead tissue, you get the contractile myofibroblasts pulling that tissue together, and then you get remodeling or rebuilding, and the wound heals. That is not what happens in a venous ulceration. So why doesn't it happen? First thing we're looking at is an unrestrained or pro-inflammatory M1 macrophage. And in order to look at that, we're looking at Iron Man. Iron, or hemosiderin staining, which you just saw in my previous pictures, iron collects in venous ulcers or venous legs, and it's specifically around the venous ulcer. So this is a chronic venous ulcer, and this side is just an acute wound. And if you look under the microscope, the blue staining is iron pigment, very little in an acute wound. The green staining is CD163, which represents the macrophages. And the red staining is proprium iodide, which is the nuclei staining, which is new cells growing. So you see in a venous wound, it looks like utter chaos because these CD16, the macrophages are, I call them macrophages gone wild, on spring break. They're all over the place going after all of this iron. They're completely distracted from their primary job. You don't really see a lot of cell growth and proliferation, but in an acute wound, it's all very organized. You see a lot of new cell growth and proliferation. The macrophages are very controlled, and it's in a lattice form. So it's in like a scaffolding form, as opposed to this whole wild situation going on here. So why is that? Iron is bad. It will continually upregulate the M1 macrophage by stimulating tumor necrosis factor alpha. But at the same time, I told you before, TNF alpha will cause a transformation of the M1 to the M2. Iron blocks that. So iron will block the transformation to the remodeling. It upregulates the pro-inflammatory cytokines, so you just get constant destruction and non-wound healing. So here's your little image of a venous ulcer, the skin, the injury, and now I've drawn in here, I don't know if you can see it well, edema. So in addition to all of that, you have this big edematous leg. So all of your signals are now diluted. So you have all this flooding, this water. In addition to that, you have iron in the water. So you get that ulcer opens up and your leukocytes walk on out and they head towards the iron and just get distracted. They start gobbling up the iron. They turn into the M1 phenotype, your undifferentiated myofibroblasts. Well, there's a sound effect I didn't know I had. Some of them do get the signal that are close by, and they do turn into contractile myofibroblasts, but the others do not. The wound edges stay open. You have constant destruction and impaired healing. So how do we fix that? Some of the things that we're looking at is etanercept or Enbrel. This is an immunosuppressant that can block the upregulation of the M1 macrophage. We also have iron chelators like desfuroxamine that can gobble up the iron. This is something that has been injected in wound edges and venous ulcer wound edges and have been shown to actually work. So now you have the M2 macrophage differentiation. And lastly, we'll look at the glycocalyx. She's the little superhero, the incredible here with her force field. The glycocalyx is kind of like a force field and a cell signal. That's what I like to, cell phone signal. It's a gel layer that lines the endothelium as a protective layer. And the thickness of it is very important. The thicker the glycocalyx, the better the protection. It's got glycosaminoglycans in it, which act like a cell phone tower and basically telling all of the inflammatory and rebuilding cells when to upregulate and downregulate. So in a situation where you have a breakdown or a degradation of the glycocalyx, such as in a venous wound or diabetes, you will see that the signals get crossed and there's fluid loss, there's inflammation, and you do not get that the cell signals appropriately transmitting. So that glycocalyx destruction is very important in non-ulcer healing. How do we fix that? There is a medication called solodixide. Now, unfortunately, this is not FDA approved in the United States, but it's used all over the world, the rest of the world, and has been used for a very long time. It contains 80% heparin sulfate and 20% dermatan sulfate. And it has been shown to actually rebuild the glycocalyx. You see here, this is side stream dark field imaging, but this is a vein wall. These black things are red blood cells, and there's like a white strip you see here between the red blood cell and the vein wall. That white strip is the glycocalyx. So if you look closely, you'll see there's a thickness or certain thickness of the glycocalyx. So that's how we can measure it. Looking at somebody, a control here and the thickness of their glycocalyx, this is 0.8. You add solodixide and it increases the thickness of their glycocalyx. If you have somebody with diabetes, natural, their glycocalyx is much thinner than your average normal person. And you add solodixide and it also increases it almost above the normal control. So there really is some measure to this. And Soloxide is widely used in patients that have leg swelling, just venous insufficiency in general. It's regularly prescribed in Europe and Asia. Another really interesting thing to look at is DOCT, dynamic optical coherence tomography. You can see the blood vessels and how they grow in a normal wound by looking at it with this spectral analysis. So just as I showed you before, normal revascularization in the skin, or vascularization actually, is in a very lattice work pattern. In a venous ulcer, if you look at it, it's in like glomerular-like type appearance, or little tiny cauliflowers. So this might explain why in a venous ulcer, you don't also see, from healing from the edges in, you see little islands or patches of tissue that develop in the center of the ulcer, because that's where the neovascularization is. An important thing to know when you are doing wound care, you might not want to scrub or debride these little islands of tissue, because that's how a venous ulcer heals. So how do you diagnose a venous ulcer? Question, do you biopsy or not to biopsy? And the answer is actually, in general, you do not biopsy or test for infection of venous ulcer, an uncomplicated venous ulcer, that is. But a complicated or chronic venous ulcer is at risk for transforming into a malignancy, and it has a specific name. And this is, I don't know if, I think I gave this question to Bob to use in Venous Jeopardy at AVLS. So if you all went there, you'll know the answer of what that transformation is. It's called a Marjolin's ulcer. Now, you can see these in any chronic ulcer, not just venous ulcers. You can see them in burns or just chronic wounds, and they're often very painful. So most venous ulcers are pretty painless for the most part. Marjolin's ulcers are very painful. And there are two types of Marjolin's. There's the flat or indurated type. This one has a very poor prognosis. And then there's the warty or exophytic type that has a better prognosis. But these are the ulcers, when you see this, you might want to consider biopsy. If you don't do that yourself, this is an indication to refer to one of your derm friends. This is just for wow effect. This is a Marjolin's ulcer in a burn victim. And these are some Marjolin's ulcers in chronic wounds. So what is the management of venous ulcers? Surgical intervention. This is where I was talking about the overload and retrograde. Pathologic perforators from overload, often when you correct the superficial reflux, that is enough. Retrograde, if you correct the superficial reflux and you still see persistent deep venous reflux and persistent pathologic perforators, think proximal disease. These are your CVM referrals. If you want a generalization, patients that have incompetent perforators in CEAP classes 1 to 3 were more likely to have the antegrade, or strictly superficial venous reflux associated perforator, and those ones correct when you do the axial vein ablations, whereas incompetent perforators in CEAP class 4 to 6 were more likely to have the retrograde or proximal vein disease, which is why when we did discuss doing virtual follow-ups, we talked about doing those in CEAP 1 to 3, because those patients are more likely to improve and correct and have a longer interval between the incidence of their chronic venous insufficiency. Whereas CEAP class 4 to 6, we should see those in person, because they are more likely to have recurrent problems, perforators we need to deal with, or proximal disease we need to identify and correct. Just some pictures of ulcers that have been treated and healed. This is just to wrap up my talk, just with some pictures before and after. But hopefully I went through that quickly and efficiently enough to leave room for questions and answers.
Thanks, Zoe. That was great.
Yeah, does anybody have questions for Zoe regarding this? There's a lot of information, especially on the basic science side of this. So I have a quick question, Zoe.
Mm-hmm.
So every time I hear this talk about with the glycocalyx, to me, it's kind of like an amorphous mess. You know, I mean, so you've got this covering over the endothelium with all these cell signaling particles in it, but I don't really understand the concept of what the glycocalyx is supposed to do. Is it primarily a cell signaling barrier? Is it a barrier? Is it
Yes.
all of it?
It is all of it. It is a barrier. So it is that one-way barrier. And I can't remember if we've done the lymphedema talk or not, but it is a one-way barrier. So the Starling principle, when you talk about the transition of fluid from the arterial side from osmotic pressure into the interstitium, the glycocalyx will allow that one-way transfer out, but it will not allow the transfer back into the venules. So when you have the fluid that collects in the interstitium, the glycocalyx is what blocks it from going back into the venous side, which is why diuretics don't work. Because if for disease in the legs, because it is not getting back into the vein, it's staying in the interstitium, and the diuretics work on the kidneys. So basically you're just squeezing the kidneys dry and leaving all the water in the legs. Now with the cell signals, yeah, all of that, the cell signaling that I was talking about earlier with the upregulation of IL-1, IL-6, the inflammatory cytokines, those are regulated and modulated by the glycosaminoglycans in the glycocalyx. So this little picture here, let's see. We're talking about the release of the leukocytes or the diapedesis out. This is the post-capillary venule. The initial signals that come out of here, or the signals coming in, if the glycocalyx is disrupted, you're not getting the initial motion of the macrophages out because they're not receiving those signals. So I like to compare that to your cell signal in a storm. So in the storm, the glycocalyx disruption prevents that initial progression, and that's why you get the ulcers that don't. Does that make sense?
Yeah, and one last question from my side. So on the venous ulcer healing side, after you've done your endovenous ablations and your USGs and you have like a non-healing ulcer, it's been 6 months and the ulcer still isn't healing, what point would you consider using more complicated wound healing products like either an appligraft or a skin graft or something along that nature?
Well, first I'm going to be looking at the perforators in the deep system to make sure I didn't miss an incompetent perforator or proximal venous outflow obstruction. But if it's just not closing, but it's nice and clean and it's not continually enlarging, which I think is what you would see with the untreated or unrecognized proximal outflow obstruction from a blowout perforator. If it is a diabetic patient and there's other reasons for them to not be healing, as long as the edges are nice and clean, I think that's the point what I would do. And the base is clean and they're not constant, and you've got their edema under control. All three of those things: clean granulomatous tissue, edema under control, and no other cause for the ulcer to not be healing is when I would use an advanced skin product. I don't know about you.
Yeah, no, I think that's exactly right. Most of these ulcers, 80 to 90% of them will heal by 6 months just with, doing good wound care and the ablations. The ones that don't heal by 6 months are the ones that you need to start considering. Maybe this wound needs some help, or the base of the wound is a little burnt out a little bit. You're not getting good granulation tissue. You need to do something to jumpstart the wound healing. But yeah, so the point is you don't use these complicated wound care products as first-line therapy.
No.
They're always for the ones that are not healing and need some help.
Correct.
And also for the rest of the group, in the chat, I posted the link for the survey so you can get CME credits. If for any reason the link isn't working, Stephanie will send out a link to Zoe's talk, and in that link in the YouTube video below it will be another embedded link for the survey. So don't worry if this one doesn't work. This is the one I was told to post at every one of the meetings so that people can go and claim credit for CME credits. All right, if not, then everyone have a great weekend. Let me know if the link is working or not, okay? All right, good job, Zoe, as always.
Thank you.
Thanks, guys.
Thank you, Zoe.